Let's talk now about another study. This is some research from some researchers, I believe from Johns Hopkins, and I've been watching their research for several years now. And this is when I first heard about this, I thought I couldn't understand how they could do this, but essentially it's the use of TPA, the only FDA-approved treatment for ischemic stroke, commonly known as a clot buster. But in this particular case, it's being used for people who have a hemorrhagic stroke. And so it seems, how can that be? How could you use that? But I'm always amazed by the data that comes from these people. And Dr. Gorelick, I know that you followed this as well. And tell us where we are now with this.
So Hanley and colleagues from Hopkins need to be congratulated. A gutsy, innovative study, and although it seems paradoxical, it worked. Again, in a small group of people. This was an exploratory or pilot study of 50-some patients. And so when you look at the pathophysiology of intraventricular hemorrhage, you're getting clots in the ventricle. They're very subject to having increased intracranial pressure and because of the blockage of the blood sticking in the ventricles, not allowing the cerebral spinal fluid to drain. So they get hydrocephalus and they get increased intracranial pressure. 75% of them may die. That is a horrific statistic. Mm-hmm. So Hanley came up with the idea, let's sprinkle some clot buster on that. We'll dissolve the clot. The blood will drain out. We'll save the patients. And sure enough, the reduction in morbidity was, quite substantial in terms of lowering that problem and lowering the risk of death. So this is a preliminary study. It's now time for the big rollout study. I understand there's a good chance that they will be funded and begin the study in the not-too-distant future. Mm-hmm.
So very exciting, and something that's really, to me, shows, as an example of the science of medicine at work, a very innovative thinking.
Very carefully done, very carefully thought out. Again, Hanley and colleagues should be congratulated. This is big.
Mm-hmm. And this stroke, I'm trying to recall, I may be mistaken about this, but is this seen perhaps a little more often in a younger population, or is there an age factor there at all?
I think it varies, but it may be seen more in the younger group of people.
Mm-hmm. Frequently in African Americans. And if the hemorrhage is actually towards the middle of the brain, it's much more likely to go into the ventricles and cause all of the problems that he mentioned: hydrocephalus, increased intracranial pressure, and those are often the things that clinically may show up later after the hemorrhage has expanded.
Yeah.
And
hemorrhages are bad for the brain. We know that intracranial hemorrhage, the mortality may be as high as 50%. In this subtype of intracranial hemorrhage, specifically intraventricular hemorrhage or IVH, it may be up to 75% mortality. So that is horrible, and here's some hope.
Yeah.
So speaking of hope and interesting findings, this, as I said, will be our last roundtable discussion. So when I wrap up a meeting, I always like to ask the researchers and the meeting organizers, share with me your pearl. What did you learn here that you're going to take back? Is there something? And there's not always a specific thing, but when you leave San Diego, what are you taking home with you besides your suitcase?
Well, I chaired a session this morning on preventive strategies, and it was there was some really excellent presentations there. And one of the studies that I thought was really very simple and elegant was to look at patients who had already had a stroke or TIA. They were being treated with aspirin, 81 milligrams, by their practitioner. And what they did was check platelet function aggregometry, it's called, to see how many of these patients were resistant to the aspirin. And so in the patients who were not metabolizing aspirin the way they should, they increased the dose to 162 milligrams. And the majority of those patients actually showed signs that their platelets were responding again to aspirin, whereas with the half of that dose, they did not.
Oh.
So, but once they went up to 325 milligrams of aspirin, there was really not a major improvement in the platelet response. And so what that says to me is that we sometimes feel that we should go from 81 milligrams to 325 milligrams of aspirin if somebody has failed aspirin. In other words, they've had an event with a low dose of aspirin. And I think what that study tells me is if I'm actually going to make a change, I would double the baby aspirin, and if that, I didn't feel like that was sufficient, that I would probably move on to a different antiplatelet therapy altogether. But I thought that it was a nice way of kind of showing there are a lot of different aspirin resistance and platelet function assays, and this one seemed to me to be a very highly significant validated type of assay, and I think it would be useful if we could actually start doing that in the clinic.
I find that interesting because that sounds like a use of a new technology to sort of reinforce an old teaching: start low and go slow. I believe weren't those words too?
That's right.
I thought they were embroidered someplace. What about you, Dr. Gorelick?
Well, Dr. Bushnell's pearl is going to be tough to beat. That's a real treat and pearl. So that's something you can take back home. Let me try to interest you in another.
Okay.
I was chairing a session today about maintaining cognitive vitality. Okay, important to all of us. Isn't that what we all worry about? Our brain going sour, can't think, can't remember, etc. Dementia, cognitive impairment, those are the horrible words that we all fear. So we had a presentation about exercise. Exercise, and this is not just mental exercise. This happened to be aerobic or physical exercise. Guess what? Aerobic exercise will help you maintain your gray matter, help you maintain your brain volume possibly, keep your mind healthy, your heart healthy, your arteries healthy. So it's a win-win-win. So think about that. Keep the aerobic exercise going, and you may be preserving cognitive vitality. More information, more data is needed on this, but it looks very, very promising. It's good stuff.
Well, that's interesting, too, because that sounds like, we hear a lot about exercise for the heart, and we also hear about eating heart healthy, and in recent years there's been a lot of studies reported where a heart-healthy diet is also a brain-healthy diet. So maybe what we're saying here is that we treat the whole body here. We exercise our body, we exercise our mind, and we take the right type of energy and the right amount of energy into our bodies, and then to live a long and healthy life.
And drink
Absolutely.
tea.
And drink tea. Yes, as we heard a lot about that here today. So, well, this is our final session, as I said, at the American Stroke Association this year, but we'll be back again next year in San Antonio for the American Stroke Association's meeting. I'm Peggy Peck, MedPage Today.